Is there a role for adrenaline in the treatment of a patient with acute exacerbation of COPD? And what does the literature say in regards to the use of adrenaline in COPD?
In a patient with COPD, there's usually also some element of heart failure or ischemic heart disease, and giving adrenaline has a higher risk profile in patients with heart disease. Also, it isn't a true bronchospasm in the same way an asthma patient has, so there's structural changes that are permanent, so adrenaline doesn't get to act on the smooth muscle and relax the smooth muscle in the same way that it would in an asthma patient. However, some COPD isn't always a disease in isolation. Some patients have asthma and COPD, and in those cases it would be considered, and that would generally be a younger patient who has had lifelong asthma, or likely to have had asthma as well as their COPD, and in that case adrenaline may be indicated, so it is on the protocol.
And what about the Australian guidelines for the management of COPD? Does it currently include adrenaline?
No, it doesn't.
And is COPD, we see it with asthma patients, from an asthma attack a fully reversed condition. Is in this case COPD, is it fully reversible?
No, COPD is a chronic condition with permanent structural changes and permanent inflammation to the lungs, and they're not reversible. They're just symptom management and exacerbation management.
Well said. This patient has a gradual build-up of respiratory distress. What clinical pathway of recovery would you expect in this patient? And I think by this they mean, do you want to explain this? Do you kind of get that?
My understanding is that a patient who has had a slow onset of exacerbation of their symptoms will usually have a slow recovery and require more management. We wouldn't expect them to bounce back rapidly. So we'd be predicting possible ICU admission for a severe exacerbation that has been increasing. Also on a background of taking steroids already. It sounds like they were already a compromised patient, either with a severe disease or already suffering from an ongoing exacerbation. And now this is an acute and chronic exacerbation. So I'd expect a slow recovery and a lot of management required.
Perfect. Can you explain how so this is a bit more specific to asthma it seems, but explain how hydrocortisone works in asthma patients.
Hydrocortisone is an adrenocorticosteroid. It works by reducing inflammation, so it interferes with the inflammation process and the mast cells and cytogens at the site of the inflammation. It reduces their effect. It's like a slow onset, so usually 2 hours time of onset, and it will reduce the mucus production and the inflammation at the lower airway level, so that aids their recovery.
Perfect. Is there something about, I shouldn't say something about, in terms of its administration and when to administer hydrocortisone, do you think there's a need for it in the pre-hospital field? Do you think it's something in the hospital with knowing that?
Even with short transport time, the earlier the hydrocortisone is given in the exacerbation, the sooner it will start to work. So the 2 hours from when it's given, if it's given half an hour earlier in the pre-hospital setting, then the person will start to feel the benefit half an hour earlier than if it's delayed until in hospital. And unless you have very long transport time, you're unlikely to actually witness the improvement, but it will happen and the patient will benefit.
Does it reduce the need for hospital admissions with the administration?
In a patient that we are giving hydrocortisone to, they're still going to require transport and management in hospital, but yeah, it reduces their ICU admission rate.
That's good. few other things, but in particular we'll make the boxes. So there's a few other things here. Failure to treat with steroids may contribute to asthma deaths, fewer relapses after both 7 and 10 days. They require fewer doses of B2 agonists. I remember reading about hydrocortisone, and it has speculation that it actually improved B2 receptors.
Okay.
Was in the language, and that's what it says, require fewer doses. Fewer relapses in the first week requiring hospitalisation and reduced admissions rates. It's quite odd points that are like little extra points. I don't think they're ones that scare me. But let's say them anyway because they're here.
Yep.
Can you tell me about hypoxic drive? Why does it occur, and how do we manage hypoxic drive?
In patients with chronic respiratory conditions, such as COPD, they have a continuously higher level of CO2, so they fail to blow off CO2 in the same way as somebody without any chronic respiratory conditions. And the chemoreceptors become accustomed to the higher level of CO2, so that doesn't drive the respiratory rate and depth in the same way as it does in a healthy person. Instead, the person relies on their oxygen saturation level, and the presence of oxygen is what manages their respiration. So if those patients are given a high level of oxygen, like if they're brought to 100% saturations for a period, then the body believes that, or the receptors believe that there isn't a need to breathe as much, and as a result the person can become apneic or unconscious, and their respirate drops and their CO2 climbs, which also contributes to them having like a carbon dioxide, like a narcotization from carbon dioxide. So they...
My apologies. I unfortunately got caught on a couple of jobs. I was planning to be back here for 3.
Oh, Damo was here as well
Oh,
as
was it?
as well as
We
Ricky.
came in.
Yeah, they came in. just
Okay,
now.
so you're going through it now?
Yep.
If you want, you're welcome to stay on this lengthy
Oh.
questions.
So that's why our high percentages of oxygen saturations in people with chronic respiratory conditions are avoided.
Yep, that's a good answer. So I was reading to make sure we get every point. What's your management of hypoxic drive and COPD patients? What's your target for your SpO2?
Ideally between 88% and 92%.
Perfect. And what does that allow?
That allows the oxygen level to still be low enough to drive the respiratory function.
And it also talks about just the lower O2 levels in the pulmonary artery vessels added. So getting the high levels of O2 can cause vasoconstriction. So you get a greater BQ expansion. But I think you tick the major boxes. I think that answer is thorough. It's good. There's a bit more that they started here in terms of CSS and medulla and hydrogen ions, but it feeds to those major points. I think it's really that major collection of points, and yet you were really thorough in that. So, but just letting you know you looked that afterwards. Okay, what is the evidence supporting invasive and non-invasive ventilation in COPD?
There is evidence that non-invasive ventilation improves outcomes, decreases hospital stay, decreases ICU admissions. But there is very little research into CPAP. It's almost all BiPAP because logically biphasic like the BiPAP process makes more sense, where they can have a lower level of peak, but they can have a higher level of inspiratory pressures. So most of the evidence is about BiPAP, and there's very little evidence about CPAP, so it isn't recommended in the Australian guidelines.
This is non-invasive ventilation, CPAP and BiPAP. It's good evidence for the use of non-invasive ventilation, COPD, but it's still controversial in asthma. Chronic bronchitis, obstructive airflow due to edema, necrosis, fibrosis, recurrent infections, bronchial tree. Advanced COPD can result in hypoparic ventilatory failure, and CPAP reduces PA CO2 and helps prevent intubation in hypercolic patients with severe respiratory stress. You know, the one thing about these studies, this is my particular opinion, I think that it is sometimes a consideration in these patients for CPAP. However, in our field, we are unable to control the oxygen delivery in CPAP. And I think that's a major concern that we have in our pre-hospital field with our current equipment.
Yeah.
And I think that your
you
understanding of the
pressure
BiPAP,
without the gas.
whether in hospital, I'm
Yeah.
quite sure that they can control the pressures and actually put low flow
Yeah,
oxygen
they can
on.
put air pressure through it rather than oxygen
So it
pressure.
seems like a bit more of a safer option for these particular patients.
Yeah.
However, I think sometimes in these really severe ones, we are going to be put between a rock and a hard place, and consideration should be there.
Yeah.
That's my feelings. I don't know how you feel about it, but the majority of the time, you're not going to be requiring it. But you're going to know that they're going to get in hospital.
Yeah.
However, the risk benefit we're going to have to toss up at times.
Mm-hmm.
And if we were to, you either set up on that particular scene, I'm going to consider CPAP in this particular patient. What other things would you be considering that you'd be delivering through that CPAP? And what would you use?
So you could continue to give the nebs through the CPAP if you use the T-piece
Yep.
in the nebulizer,
Perfect.
and that will continue to deliver.
Yep. That's good. But yeah, that's my thoughts on CPAP. I just don't think we have that oxygen delivery control at the moment. I think that there's a great risk with that. However, at the same time, I think there's going to be a time where we're kind of feeling that it's the right thing to do, and that's just based on patient assessment.
Yeah.
I've had one where I've held it. I wish I could have it. But at the same time, there has to I think just the nervous being fine.
Yeah.
And just because of those reasons, those high flows.
And the high pressure then.
Yeah, exactly. I think the pressures are okay. It's just the O2 delivery that really kind of makes me a little bit, and sometimes we're unsure if they've got a serious irritators or not. All right. So I just want you to talk about the cost benefits of CPAP in asthma. It's very it actually states a few studies. If you'd like to state any studies, it's fine. However, I'm happy if you're able just to kind of tell me some risks associated with CPAP and asthma, and obviously the benefits associated with asthma patients and CPAP. I mean, you're quite welcome to mention studies if you
I
like.
haven't done any studies in my head.
But I think talking about it is having an understanding.
My understanding is that it assists in splinting the lower airways, like the bronchioles, which reduces the work of breathing and assists with oxygen delivery to the actual alveoli. The risks, these patients have already got a high intrathoracic pressure, so you've increased risk of giving them a pneumothorax. If they vomit, it's an increased risk of aspiration, and it can be very distressing for them. So you've an increased risk of anxiety, and then not tolerating the management, and then ending up without even oxygen flow.
Would you be concerned about the potential for hypertensive episodes due to increase intrathoracic
The
pressure?
intrathoracic pressure can reduce the preload, returning back to the heart, and then increasing that further with continuous positive airway pressure can affect their cardiovascular function.
Perfect. And in terms of just back to the benefit as well, you mentioned reduced workload breathing. In terms of the resolution of symptoms, with the consideration of CPAP in asthma patients, in particular severe asthma patients, potentially resolve the acute episode a little bit more quickly.
It's certainly good. It'll improve oxygen delivery,
Yeah.
and it will prevent mucus plugging
Yeah.
and alveoli and bronchial collapsing and atelectasis.
And respiratory failure due to fatigue. Perfect. All right. Let's turn the thing off. That's great. That's well started enough.
Oh yeah.